All right, so we're going to talk about differences between the left and right ventricles. The right ventricle is this part right here, or this chamber right here. So this is the right ventricle here. It produces less pressure than the right ventricle, than the left ventricle. Why do you suppose? Why do you suppose the pressure produced in the right ventricle is not necessarily as high as what's in the left ventricle?
It doesn't have that deep layer of muscle.
Well, that's how, but why?
It's not going to the tissue.
Yeah, it's not going all the way down to your feet and all the way down to the tips of your fingers and all the way up to the top of your head. It's just going right to the heart, right next door. And the resistance is less in there, and so it just requires a lot less pressure. So the right ventricle is a pouch off of the left ventricle. And the left ventricle is this huge, thick walled chamber, of course, on the left side. So let's talk about the one-way valves. The one-way valves are there to prevent backflow from the ventricles into the atria. And the first ones we're going to talk about are the AV valves, the atrioventricular valves. They're, of course, between the atria and the ventricles. Here's the right one, and there's the left one there. So what happens is when the ventricles begin to contract, what's going to happen to the pressure in the ventricles? Up, does it go up or down? It goes up, right. And that's going to force blood out of the ventricles, whichever way it can go. And what happens when the pressure is low in the ventricles is blood flows into the ventricles through the one-way valves here. And when pressure builds up in the ventricles as they contract, it tries to leave through those same valves, but the valves themselves, the cusps, catch the blood and snap shut. They're kind of like sails on a sailboat, except they catch the wind, they kind of go, and that pulls the sailboat along. In this case, it just closes and seals off the atria from the ventricles, so now there's only one way to go, and that's going to be to the systemic circuit on the left side or to the pulmonary circuit on the right side. So remember there are those chordae tendineae, these little guys right here. They kind of act like the ropes on the sails to hold the tension just right. And the papillary muscles are these guys right here. And they create just the right tension so that the flaps of the valve or the cusps of the valves don't flap backwards up into the atria and allow blood to escape back where it came from. Yes?
I don't really understand how the cusp will be closed when, I forgot what those are called, when those are contracted.
When the papillary muscles are contracted, these
Yes.
guys? So, let's see. Escape this thing for a second. All right, so if we zoom way in on the heart here, which we can do here. If we zoom way in on the heart, you can see there's the valves, and the valves are kind of held. These are the valves here. These are the cusps here, here, and there's the ones there's three of them over here. And when the pressure is high here, it just pushes these guys open because there are flaps like this. When the pressure builds up in the ventricles, the pressure is going to try and push the blood back into the atria, but since these big cusps are here, it kind of fills them up and they then shut like this and block off the atria. And basically the papillary muscles are attached to the chordae tendineae, and they're just holding the tension so that these cusps don't either stay open and allow the blood through back in, or they are not too loose so they don't just flap back in here and allow the blood back in. So they basically keep, come on you.
They keep it stabilized in a way.
Sorry?
They keep it stabilized in a way?
Yeah, they just basically keep things stabilized so that it's just the perfect tension, so that like if you have sails on a sailboat, you have to keep the tension just right so they keep holding the wind and they don't just flap like flags. That's the idea. Is we want to keep them from flapping like flags. I don't know where it went. Anyway, we want to keep them from flapping like flags and allowing the blood to flow back to the atria. So, and I'll show you another picture that illustrates it, actually in the next slide. All right, so, right. Okay, so here, this is the left ventricle, and as it contracts, the pressure goes where? Up or down in here?
Goes up.
Up. So pressure goes up, and then that's going to try and force the blood out. It's going to try and go back to the atria where it came, but you can see the chordae tendineae and the papillary muscles are holding the valves such that they fold up just right, catch the blood, and shut off the blood flow up. So the only place now for the blood to go is out through the aorta to the pulmonary, to the systemic circuit. Now sometimes the chordae tendineae get damaged, or the valve itself gets damaged, or maybe the papillary muscles aren't working properly, and blood escapes up into the atria, and that's called regurgitation, or backflow of blood where it's not supposed to go, because we want the blood to keep flowing through the heart and to the systemic circuit on the left side and the pulmonary circuit on the right side. So that's the deal. Stopping the backflow, something you get a little bit of regurgitation, but it's not a big deal. But if a lot of blood goes backwards, then we're not efficiently moving blood through the circuit and to the next part that needs it. Okay, so here's a relaxed heart. What's the pressure going to be like in here? It's going to be low. So now the pressure up here with the blood flowing in, it's going to be higher. That opens the valve and fills the heart. So when the blood flows up into and this is the left side, when the left ventricle contracts, it's going to push blood up into the aorta, right? Because the valve is going to shut off blood going back to the atria. And when that happens, the pressure in the aorta is going to go way up. And then as the ventricle relaxes, the pressure goes down, and the blood up in the aorta is going to try and flow right back into the lower pressure ventricle. But it can't, because those little semilunar valves snap shut. They don't have chordae tendineae and everything. They're just these little cups of connective tissue that form the valve, which keep the blood flowing now from the aorta out to where? To the rest of the body, to the systemic circuit, right. And the same exact thing is happening on the right side, only it's going to the lungs and the pulmonary circuit. So this is what the little valves look like if you remove the atria and look straight down on them when they're closed. So these guys have these little 3 cusps, that's why they're called tricuspid valves, or or they're called semilunar valves most likely, or they're called by their name. On this side, it's the aortic valve, and on the other side, it's the pulmonary valve. Okay, so I need to explain now about the aortic sinuses. So the aorta, here's the aorta here. There's a little bulge at the base of the aorta, right where it attaches to the ventricles. And those are called the aortic sinuses, and it does a couple of things. When the semilunar valves are open, this bulge keeps the semilunar valve from coming back and kind of attaching to the sides and getting stuck there, sticking on the aorta. But the other thing that they do is, so when they're closed, the valve will look like this. When they're open, the little cusps open up and they cover over the sides of the aortic the aortic sinus. And these blood vessels that are coming off of the aortic sinus are going to the heart muscle itself. These are the coronary arteries. So blood flow through the through the aorta cannot go through the coronary arteries when the valves are open, because when they open, they actually block off flow to the coronary arteries. So when the pressure down here in the ventricle, so this is the left ventricle here, when the pressure goes down, then the valves shut and the back pressure tries to push the blood back into the ventricle, but it can't get there because of the one-way valves, the aortic valves. But that is the point where it flows through the coronary arteries to the heart muscle itself. So these are the blood vessels that nourish the heart muscle itself. And they're only open, they only experience blood flow when the aortic valves are closed in a period called diastole. And diastole means expansion, dilation, or relaxation of the heart. And I'll mention that again a little bit later. But it is important to know that the way the aortic sinuses and the valves are arranged, the only time blood flows through the coronary arteries to the heart muscle itself is during relaxation when the aortic valves are closed. Okay, so carditis. What is carditis? So it's inflammation of the heart. And oftentimes when there's inflammation of the heart, the inflammation in the area around the valves will damage the connective tissue, and you'll get what's called valvular heart disease, where the valves become stiff and unflexible and they don't close properly because of scar tissue building up on the valves themselves. Rheumatic fever is a systemic infection which tends to infect the inside of the heart, and that inflammation damages the valves. And then the valves don't shut properly and they don't open properly, and then you wind up needing to get a valve transplant. All right, let's talk about connective tissue, fibers in the heart. There's lots of connective tissue which helps form the shape of the heart and support the muscle fibers. Also, it distributes the contraction forces, so you get a nice smooth contraction and push blood out of the heart. Also, that adds strength to the heart and prevents overexpansion of the heart, because we don't want the heart to become overexpanded so that it can't, so that it gets overstretched. And we'll talk about why that is later on. There are also a lot of elastic fibers in the walls of the heart, and that way when the heart fills with a lot of blood, it can kind of just use that elastic rebound, like in a balloon full of air, to help push the blood back out of the heart. Okay, so there's a very, very, very important structure that we need to talk about now called the fibrous skeleton. And the fibrous skeleton is this area of tissue, of tough connective tissue that surrounds the valve. So here we are looking up into the ventricles, and we can see there are the AV valves on the right and left side, and that would be the aortic valve there. And all of these structures are surrounded by this tough tissue, which helps support the valves and give them structure so they don't collapse. And that's important, but the most important thing that they do is they are the attachment point on the ventricles for the atria. So basically, they separate the atria from the ventricles, both mechanically, because they are in between the two tissues, the two muscle tissues, but also, very importantly, electrically. So the way the electrical signal travels through the heart to cause the muscle cells to contract is through gap junctions, through the cells. So it spreads from cell to cell to cell to cell to cell. And that happens all throughout the atria. So anywhere you have a depolarization in any part of the atria, it'll spread through the entire atria. Same with the ventricles. But since you've got this fibrous skeleton separating the atria from the ventricles, the atria and the ventricles can act independently. Has anybody heard of AFib? What is AFib? Well, it's atrial fibrillation. So your atria are contracting just randomly and they're not moving any blood. But are people with AFib dead? No. They're tired, they feel bad, they might be lightheaded, but they're not dead because of the electrical separation between the atria and the ventricles. The ventricles can work separately and independently, and they don't stop just because the atria are not doing their job. And this will make a little more sense later on when we talk about electrical signals in the heart and how they move around. Okay, how is the heart supplied with blood? We're going to talk about coronary circulation now. There are coronary arteries that are supplying blood to the muscle, and coronary veins, which are picking up the blood, the spent deoxygenated blood, and bringing it back to the heart. The coronary arteries, so this is the anterior view of the heart, and we've got the little semilunar aortic valves, which cover over these arteries when the valves are open and blood's flowing out, and then when they close, the blood can flow out through the left and right coronary arteries. So again, remember, the blood is only going to flow through these coronary arteries when the heart is in relaxation, when it's not contracting, when those valves close and we uncover the coronary arteries. So one of the reasons for that, and I always wondered about that, but one of the reasons is that when muscle is contracting, it's very hard to get blood through it because it squeezes all the arteries that are embedded in it. So it makes more sense to have blood flowing through during relaxation because that allows the blood to perfuse the muscle more easily because there's less resistance to flow because not all the arteries aren't being squeezed by the contracting muscle. Okay, so the right coronary artery here supplies the right atrium and the sinoatrial and atrioventricular nodes, which we'll talk about later on. Also, the marginal arteries, which are coming off here and they're going to the surface of the left and right ventricles. And also, it goes around the back of the heart here to, let's see, that's the wrong side. It goes around the back of the heart. So this is the back of the heart here to the posterior interventricular septum back here, which is our interventricular sulcus back here. Okay, so the left coronary artery now is coming off this side, and it's supplying both the left ventricle, the left atria, and very importantly, the interventricular septum, which is this divider in the middle between the ventricles. And there's two main branches. One is called the circumflex branch, so it circumnavigates, goes around to the back of the heart. And then there's the anterior interventricular artery, which goes between the right and left arteries through that interventricular sulcus. And remember, again, this is very important. The blood is only going to flow into these arteries when the heart is relaxed in diastole, which means what are the valves? What's going on with the valves here? They're closed yet, because when they're open, they block. And you'll actually be able to see this, hopefully, in your dissected heart. You'll be able to see the little coronary arteries and see how the valves cover them over. Okay, so here's a term that I need to mention. Arterial anastomosis. This is a general term which means you have two separate blood supplies or two separate arteries that are supplying the same tissue. And here we have the anterior view of the heart, and we've got the anterior interventricular arteries going to much of the tissue towards the apex of the heart. And back here on the back side, we've got the posterior interventricular arteries also going down towards the apex. And if you look down here, you can see that a lot of these arteries connect. So we've got multiple blood supplies to the same tissue. Why would that be important in the heart? What would happen if one of the arteries got blocked? The tissue would die. And it does, depending on where it is and how many different blood supplies there are. But this is a way of providing extra blood supply to the same tissue because it's so important. If there is a problem with blood supply on one side, there will be a little bit of blood from the other side. Okay, so the great cardiac vein is this guy here. It's coming around. It starts over here, and it comes around the back, and it goes up to this swelling called the coronary sinus. Then the anterior cardiac vein are these little guys over here, and they are the only one of these veins that empty directly into the right atrium themselves. All the other veins, the posterior here, the middle cardiac vein, and the small cardiac vein coming around from the other side, and they all either dump into the great cardiac vein or the coronary sinus, which the great cardiac vein dumps into also. So again, only those and the anterior cardiac artery veins dump directly into the right atrium. All the rest of them go to the coronary sinus. Okay, so you guys ever heard of angina? So angina is chest pain, which tends to be temporary, and it happens when you're exerted either emotional stress or physical stress, and it comes from a partially blocked artery. So here we've got a normal, nice open artery, and this one has atherosclerotic plaques. It's partially blocked. And what happens is sometimes when the oxygen demand goes up, you don't have enough blood going to that tissue, and that can cause a spasm in the tissue, in the blood vessel, which further reduces blood flow to the tissue, and you can actually cut off the blood supply, maybe not completely, but to a large extent, and that causes pressure and pain in the chest, and it tends the typical pattern for chest pain from from the heart, pain emanating from the heart, is that it goes up into your neck or on the left hand side and then down the inside of your right arm. Now this is the very, very typical pattern of pain in adult males. Unfortunately, in women, there's a lot more variability. Some women don't have any pain radiating down the arm at all. Some of them, the pain stays all the way up in this area here, and that's a problem because if everybody studies this map here, and then a woman comes into the ER and says, I'm having this pain right here, and they give her an antacid and send her home because they think she's having heartburn, that's a problem because she needs to be treated. She may well be losing heart muscle here. So that's why these days if you come into the ER and you even utter the words chest pain, they'll take you back immediately and start a cardiac workup, hopefully, to try and at least rule out that it is coming from your heart. So for treatment here, rest, nitroglycerin. You guys ever heard of nitroglycerin? They give it to people with angina pectoris. Anybody know what it does? It's a very powerful vasodilator. So it opens up, it relaxes those. It also gives you a powerful headache, apparently, because it dilates all the blood vessels in your head, and then that starts pushing on pain receptors. But better that than having your heart muscle die. Other things you want to do is limit the triggers, like if it's exercise or stress-induced. Stop smoking. Smoking tends to make your blood vessels very reactive and cause spasms. And also toxins can damage the walls of the blood vessels, which leads to cardiac artery disease. Also, lowering fat consumption. So lowering your fat consumption means that you have less fat, or changing your fat, making sure you switch over to the unsaturated fats, which means less cholesterol in the insides of your arteries. The other thing they can do is surgery. They can go in and put a catheter in, like a balloon catheter, and try and open up these partially blocked areas. Sometimes they put a stent, which is a little spring that holds them open, but there's problems with that because they tend to form blood clots on them. But it's important to do something. The other thing they can do is coronary bypass surgery. So let me show you what coronary bypass surgery is. This is a heart with an area, and if we zoom in on this area right here, we see a little part of the artery that is almost completely obstructed. So very little blood flow is getting through here, and when you tax the heart, you're not going to get enough blood flow to this area, and you're going to wind up with angina. And what they do is they take a vein out of your leg and attach it to the aorta up here, and then blood flows through the vein. They attach the other end right past the obstruction, and now you've bypassed the area of obstruction. They can do a single bypass. They can do they could do a double bypass, or a triple or a quadruple bypass. They say the worst part of this surgery is they take I think it's the great saphenous vein out, and it's really painful, the recovery from it, because they go in, they have to dissect it out, and it's really bad. But
Now, why couldn't they just unblock the obstruction? Would that be like the stent?
easier said than, yeah, I mean, sorry?
It's like
Wouldn't it be more
infrastructure. Some tunnels.
complicated?
It can be more complicated. It often won't last if they go in there with a balloon.
Yeah.
The stents can cause blood clots to form. This way, they're just bypassing it, and they know it's going to work because it's been done for years, and the blood vessels, the veins tend to do really well. They're getting plenty of oxygenated blood. They live, and it works. Yeah.
If that little yellow thing which is about to close, if that does close, is that like a heart attack waiting to happen, or?
Yeah, see, that's the problem. We're going to talk, well, let's talk about it right now. So, myocardial infarction. This is where we've got a narrowed area of artery supplying one part of the heart. And now that there's a narrowed place, it's very susceptible to an emboli, like a blood clot, that breaks off from somewhere for some reason and lodges in that narrowed area. Now, instead of having a narrowed area, we have a completely blocked area going to a part of the heart. And the area that isn't getting blood flow, the cells die. And then you have part of the heart muscle non-functional, and these cells don't grow back. If you were to go in there a day or two later and open up this artery or do a bypass, these cells would not return. That tissue gets replaced with scar tissue. So you have a non-functional part of the heart, and also the heart is less flexible now because it's got all this scar tissue in it. So this is very it's very important to understand that. And when you want to go in and reverse this, you've only got about, I think they say 3 to 4 hours. If you wait 3 to 4 hours after the blood supply has been cut off, the tissue is irreversibly damaged. So the longer they sit there, the more chances the permanent damage. And you guys ever heard of Doylestown Hospital? So I think they have a huge cardiac cath unit. That's their big thing. And they used to have a commercial that would guarantee that they would have you in the cath lab in under 90 minutes from the time you showed up in the ER. So it's very, very important if you're having chest pain to get to the ER immediately so they can go in and get you in the cath lab and open up that artery. Because if you wait a few hours, there's no going back. If they'll just pop open the artery. They have this little thing that can actually fish the clot out now. But they had a commercial that said, we got you in the cath lab in under, I think they actually might have said 45 minutes, I want to say, but they got to prep you, they got to get a team together and everything. So they were, in their tagline in their commercial was, because time is muscle. And they didn't explain it, but it was perfect, right? Because the longer you're waiting for that cath lab to open up that artery, the more your heart muscle is irreversibly dying. They stopped using that commercial product because nobody knew what they were talking about. But
what if they didn't get you? Was there like a coupon if you didn't?
Yeah, free heart transplant. Yeah. I don't think so. But the idea is, if this is what we're geared to do, and you come to our hospital, you got a much better chance than if you go to Lansdale, Abington, where that's not their thing, and they might have to transfer you to Doylestown, which is like 45 minutes away, and you've already been there being evaluated for an hour. So, yeah, not so good. Okay, so signs and symptoms very similar to angina pectoris. You get crushing pain in the chest, and it tends to radiate down the left arm, but not always, especially in women. And here's a very good way that you can tell for sure whether it's an MI or maybe just some angina pectoris. You look in the blood and look for cardiac enzymes. Because if the cells are dying, then their membranes start to lose their integrity, and they lose their creatine kinase and troponin. Remember those guys from the skeletal muscle? But you also lose an enzyme that's particular to the heart called lactate dehydrogenase, because heart muscles, as we'll see later on, can use lactic acid as a fuel directly. So if you're seeing all these enzymes in the blood and the person's having chest pain, then you can be pretty sure that there's damage being done to the heart muscle. So the treatments could include fibrinolytics or clot busting drugs. Does that make sense? Why?
So there's no clot to block the blood flow.
So so what you're doing is you're going in and you're actually going to dissolve that clot, right? Would you want to give acutely means right away, right? Would you want to give somebody an anticoagulant right away? I mean, they do actually, to stop further clots, but is that going to dissolve that clot? No. It's just going to stop further clots from forming. But chronically they give anticoagulants. Why?
So you don't make new clots.
Exactly, to reduce your clot formation, so you have reduce your chances of a clot coming in and being lodged in one of these partially clogged arteries. And that's why older people often take those little baby aspirin. It's like 75 milligrams, I think, and a normal dose for pain relief is like 350, I think, something like that. All right, let's see, where are we here? All right, you know what? We're ready to stop. So why don't you guys take about 10 minutes? It's 2:14. Come back at 2:24, and I will have some hearts for you to dissect.